think we're missing a panelist. No, you as well. I'm standing. Rick got the privilege of a chair, but I have to stand. All right, well, I just want to thank everybody for staying with us and thank our afternoon speakers. It was a very, very interesting set of discussions. I thought they tied together really nicely. And along those lines, I want to ask a question around something that kind of unites, I think, all the talks, which is, in your opinion, what are the most important differences when we think about psychedelics and psychedelic use and how that should inform data collection? Maybe I'll ask you to go last.
For me, just because I'm working on a self-report survey, I really want to understand the influences of the culture and the terminology on how people respond to these questions and how us as academics or researchers might, like seeking medical care. I might interpret that very differently than someone reporting on this survey. And so I want to put a lot of effort into listening to these communities and understanding the correct terminology and the right questions to ask so that we can have feedback loops to both government agencies to make informed decisions, but also give back to the people who are using these substances to make things safer and effective for them. So I want to make sure we cover the whole spectrum. And I think part of that is really understanding the correct way to ask these questions and the right way to reach people where they are.
Yeah, great thought.
Yeah, I want to reiterate that. And as a provider, it's like, I want all of the providers to get this data. I want providers and facilitators to be able to get this type of feedback. And I think that to answer your question, really it's about kind of this use matrix. It's about setting and substance and dosage and motivation, because it is so complex for the differences in psychedelics and for the different use profiles. And so I really think that we're starting to kind of build a mycelium network of information around psychedelics, and it's growing in that way. It's like really kind of growing in this, creating an umbrella of services.
I couldn't agree more. Certainly the language is going to be important. I still think there's wide divergence on what we mean sometimes by psychedelics versus hallucinogens, but also I think balancing, just like we did with every other therapeutic intervention, the risk benefits. If we can make that part of, I would say, education, standard curriculum, we will reduce the stigma that's also attached to this. Because I do believe we don't have a clear picture. This may be underreported. There's also, because of the stigma, so much of people probably aren't disclosing yet that I think we'll get there as we continue the conversation. We talk about it until it becomes less stigmatizing as well.
Wonderful.
And I guess, my comment is that as a physician scientist, I always really try to keep perspective on the entire picture, right? I want to think about people with disease that are using and those that aren't. I want to think about, people with substance use disorder and people that don't and how they're using differently. And so in order to do that effectively, we actually need multiple different data systems that work together in order to actually have the appropriate comparators, because if you don't have the appropriate comparators, then things that are easily taken out of context and you don't actually have the perspective of what's happening in the whole community. And so it's a really important piece that we focus on. And I'll just draw the corollary with cannabis, where we actually didn't do that as well, right? And so I would argue that actually some of Rocky Mountain's data was used inappropriately during that time, because they just took Poison Center data and said, look at all the adverse drug events. So, the number of calls to Poison Center are going up entirely, without taking into account the number of users that actually increased, and actually the rates were actually much, much lower, right? And also it didn't really look at the benefits for things like pain control and some of the other medical benefits as well. And so, having sat on a lot of public health committees over the past 15 years for this, it's the biggest question is like, why aren't you looking at the benefits? And I think that you need to keep that perspective as you're sort of thinking about the data overall.
Thank you. So this is kind of a similar style question, and it builds on the question that Melissa asked Dr. Gandotra earlier, but I'm curious for the others, and if you would like to elaborate as well. In your roles, what is the biggest gap that you think we need to address as it relates to psychedelic use and or psychedelic use data collection?
I mean, for me as a social worker, harm reduction, it's education. I want all the education. I want all the information around dosing and how to talk to your friends and how to reach out for help and like how to support people and build community and build, like I really think that personally, from my lens and my perspective, the way that psychedelics are going to change the world is through helping us reconnect with each other and helping us reconnect with our communities and helping us reconnect with nature. And so the more education and destigmatization that we can do to like normalize altered state experiences as part of the human experience, I think the better off we'll be.
I'm gonna have a slightly cynical answer. I do think this is a moment where we need data to make decisions, but not all data is good data. And I think we need to do our due diligence as people come forward. And I want people to vet my studies, and I want to vet other people's studies. And I want to make sure that we're putting good data out there that we can trust and believe in, recognizing that this is gonna take time to get it right and that it's gonna iterate. But I don't want to just like fire sale all the data we can get. So I want to be thoughtful about how we approach this and intentional about how we approach this. And I think a multidisciplinary approach is the way to go. But I want us to be critical of the things we see in the coming months and years and really hold each other to high standards.
Patience.
I think Erica said it best. I'd probably, the education is really truly number one. But, I'll build on what you said around the stigma as well, right? I will tell you that the more I ask my patients about this, the more I hear and the more I learn from them, and the more we become open to those conversations, and we have much more real conversations with our patients when we do so. So the discussion is actually really, really important, and part of the way we educate is by asking, right? Realizing that we don't know, and so we need to ask, and we need to understand what the perceived, benefits and what the perceived risks are, because I don't want to focus on the wrong ones that are not important to my patients.
Great. Maybe one more question before we see if the audience has any questions. This question's for Erica specifically. Oh, God. Hopefully it's an easy one. How does the data shared by Dr. Rockhill resonate or differ from your own clinical experience?
Ooh. My clinical experience is skewed since I work with survivors of harm. What I found, and we kind of touched on this last night when we all had dinner, which is, if we're saying 13% are reporting that they had inappropriate sexual contact with either somebody they know or a facilitator. And the data that I've seen that has come out of just general psychotherapy, when asked therapists if they've had inappropriate relationships with a client throughout their career, this anonymized self-report was somewhere between 9 to 12%. And that's not with psychedelics. That's just in psychotherapy settings. And so if we know that 10%, 12% of psychotherapists are going to, at some point in their life, have an inappropriate relationship with a client, and we're seeing that 13% are having inappropriate sexual relationships with their clients under psychedelics, this is a huge area of risk and a huge area of harm and re-traumatization and severe moral injury. When you are in such an incredibly vulnerable, coercive, manipulative state and you are intentionally harmed by somebody you trust, like it dysregulates you to the point where you can't leave your home, where you don't know who to trust. You like it's genuine like moral injury is what we're seeing in these in this client population, and I think that we need more safety guardrails on facilitators. We need facilitators to start holding each other accountable. We need people to be able to call people out and say, hey, what you're doing is inappropriate. Would you like an opportunity for change? Would you like an opportunity to create community repair? Would you like to hold yourself accountable in community? And I think that's really hard work. And so, yeah, I'm seeing it very like it's similar across the board.
Yeah, great. Are there any audience questions?
Hi, I'm Karuna from Shamsa, and my question is about, is there, what kind of licenses do these facilitators have, or is there some thought about licensing and people losing their license if they behave like this?
That's a very complex landscape because there are people who have mental health licenses or medical licenses, and they have a lot of training and expertise. And then there are also people that, you know, go to Tulum for 4 days and get certified as a BUFO facilitator, and then they come back to the States and they're like, I'm allowed to do this now. And they have no ethical guardrails, no ramifications. And I've seen a lot of people just make up credentials on their website or make up certifications. Like I went to this certification or I'm a licensed provider in the state of Oregon, even though I'm not operating in Oregon. I've seen that a lot. I've seen people being like, oh, I see a lot of, and this is just from my lens and my experience, is I see a lot of underground facilitators that say, I'm a MAPS trained therapist who's working in the underground now. And I see that all like consistently in the underground saying, oh, I participated in this training, and even though I don't have a clinical license or I'm not working on a clinical trial, I'm now going to go do this work in the underground. And they're using credible institutions, but there's no way to check if this person is actually trained. And so I appreciate what Oregon is doing in their facilitator facilitator directory. And I think we need a national directory. I think we need a way for people to report people who have no licenses. What I've seen a lot of is somebody says, I've been harmed by this facilitator, and then they call the Board of Behavioral Sciences or the Board of Psychology, and the Board of Psychology is like, well, they're not registered with us, so there's nothing we can do. And then that person continues to perpetuate harm. And so I hope that we come up with a really solid system to be able to have ethical providers start doing this work.
Well, I would also like to comment that, and part of that discussion would have to be the patients that have unfortunately had those experiences. I think they're going to be important to include in developing of the guardrails, not just competencies for the practitioner, but in particular for those who've gone through this, to have them be part of the solution, because I think they'll be quite creative in ways to come up with those guardrails.
Yeah, I have a question. First, it's a specific question for Carrie, but then I think there'll be some general comments too. So one of the most striking things to me is that over the past few years, working and developing our psychedelic programs, is that there's this very consistent narrative that that psychedelics are used for self-improvement. Really, it so dominates the environment that that's really the only way people talk about it. Most news stories are about that, et cetera. And yet then when we look at the data that Carrie presented, we saw for some drugs, over 50% using it for fun. So the specific question is, can you tell us, you may not be able to tell us this yet, how many of those that was their only, that they weren't saying I did it for that or maybe that and sex. I don't know, but those kind of go together. Or is there another factor in there? And then for the panel as a whole is, what do we do about this disconnect? Because I would expect the safety profile to be very different in these groups. They probably need much more than just 2 divisions, but still there's going to be many different levels of safety. And I would speculate that it's worse in patients who don't have a self-improvement or a constructive intent, but I don't know that. It may be the opposite. So Carrie, would you start?
Yeah, so on the survey now, we can separate reason by frequency and which substances they are using. It gets a little more complicated when they endorse multiple substances, but you can tie that to other information. The 2 items that are directly tied to reason is who were you with, like what were the other people involved, and where were you using. So set, 2 elements of set, I would say, are directly tied to reason. So we were intentional about that. We can be more creative with tying other things directly to reason. I do think that one of the, like to your point about the larger question that is concerning to me is that this is a very common reason people use these substances, and they might not be considering their underlying mental health conditions when they're using it for fun. And so I think that's where we need to be very thoughtful about messaging and including the unintended consequences. When you go into it with the intention of having fun, you might have an experience that is totally outside what you were going for. And I think that's something with these substances we need to understand better. And I think that's where like longitudinal follow-up or more in-depth specific surveys into topics like that can be really helpful. Does that answer your question?
That answers the data question, but I think this issue of what do we do, I think it's a harmful narrative personally, in that it leads us down a certain path, that these are all people who are trying something constructive, that these are all, hello? These are all people that are, I think it leads us down a dangerous path for both policy but also for data analysis, and that is that these are, that the primary motivator is actually to improve oneself. And I'm sure that's true for a lot of people, but we need to separate them from the ones that don't have that and not just lump them together. It gets back to your comments, Carrie, that were very good in your talk about that we need to parse all these things and understand them in context of one another. But as a general statement, I mean, well, to be more specific, Erica, I mean, do you ever run into this? Because here I'm seeing data that says a lot of people use it for fun, but I don't mean this as a criticism, but you always talk about people who are actually trying to have a constructive or a therapeutic purpose. So do you see that or not? I mean, I'm very curious.
Yeah, I mean, I see all sorts of reasons, and I see this, like unintended experience that comes out of it. And I'm also a strong believer, I've done a lot of outreach and crisis work at music festivals and events and things like that. And a lot of times it is to have fun and feel carefree and have connective experiences with friends on a dance floor. And I've always said you can find just as much healing on a dance floor as you can in a doctor's office. I mean, the depression study just came out that said that dancing is more effective to treat depression than SSRIs. And so if you combine dancing with psychedelics, then you do get all of the personal growth in these unintended to have fun experiences. And so there is this kind of overlap of pushing the Venn diagram to overlap a little bit more when it comes to self-improvement and recreational fun.
I want to underscore something Dr. Rockwell said during her talk. What she said actually is one of the keys there to respond to your point here, Rick, is that I think we need to meet people where they are, right? And I think she's exactly right, because the messaging and the harm reduction messaging at a music festival is quite a bit different than it is in Dr. Gandotra's clinic, right? And so, I think that it's critical, and again, being open to listening to the reasons why and what understanding what the possible risks are, and then communicating them as such, thereby working towards those harm reduction messages that are going to be most impactful.
I'd also, at least I agree with that completely. I'd also add in that this is also important for messaging, because this will be marketed as such, that you will always have personal improvement if you're exposed to this or if you seek this out. And that is where the real risk is, in terms of there's a subset of the population that won't experience any adverse effects, but then there are real risks that everyone needs to be aware of just the same.
Yeah.
So Leah Mix with Delphi. I think today has been a real testament to the importance of data collection and really intentional, nuanced analysis and reporting for psychedelics. And, some of the things that I'm tracking are everything from, the DEA looking at ketamine, like the opioid epidemic, right? And mitigating how the DEA might respond to ketamine clinics and ketamine use and psychedelics, to designing programming, as Cameron was saying, for psychedelic harm reduction, all the way through to how the therapeutic component, the psychotherapy, is a true risk element for getting psychedelics when psychedelics are coming through the FDA, and data collection on the other side being a very important part of that safety net that needs to be in place for those psychedelic drugs to be coming through the FDA, right? So it's clearly what is being done here is incredibly important work. So my question is, who do you see to be the stakeholders who should be calling and making a call to action for this type of data collection and analysis to go into a place in all the places that it needs to be? And then where should that funding come from? Because this does not happen for free.
Biotech. I think people who are going to profit off of making these medicines should be funding harm reduction programming and education. I think big pharma should be funding harm reduction. I think that they need to implement bigger social programs because they know it's risk mitigation, and they know that there's a risk, and they know that whatever medication or medicine that they put out is going to have a small percentage of people that are going to get harmed. And if we've learned anything about psychedelics, the trickster energy is there, and if you're going to try to profit off of this, it will throw you for a loop. And it will figure out a way to, like, if you're not in ethical right relationship with these medicines and plants and things like that, it will figure out a way to trip you, slow you down, turn you around, confuse you. And so if you have to be in ethical right relationship and you know that you are profiting off of something that is going to create societal good, but also harm this, whether it's 5% or 7% or 13.5% or whatever it is, you also have to pay attention to that. You can't ignore that. And so I think a lot of funding needs to come from private big pharma biotech companies. Please fund my nonprofit.
I won't speak to federal funding. We have continued investments, and that'll be up to our policymakers to appropriate that. But I will say there are some places where data could be more readily accessed, or I will say that it might be lower hanging fruit. Certainly tribal communities are going to be one place. Our veteran community is probably the other place where we already know that this is occurring, and we should be able to leverage access to that data. Aside from that, certainly I'll go out on a limb, probably the DoD would be interested as well.
It may sound naive and somewhat pie in the sky, Leah, but I would suggest to you actually that really this is a community solution, right? There is no single funding agency that's going to provide the funds to do this, right? So, I agree, biotech should cover some of this. I agree that the federal government should do some of this. I think our local state government needs to do some because they're rolling out new programs as well. we're putting a lot of time and energy in on our own regard. And so we are putting this energy in because we think it's important to demonstrate both risks and benefits. And so I think ultimately we're going to be talking to community leaders that have initiatives that need to be funded as well. And so inherently, just like Erica spoke about the care of an individual patient and the rolling out of this as a community effort, really we're all going to actually have to share some of the cost of this. And some of that cost is just going to be the sweat equity that, Dr. Rockhill, Dr. Korthus, Dr. Ray, and Dr. Black have already put in because they think it's an important thing to make sure that we're putting valid data out there and advising our patients.
Jess, anything from the online audience?
Yes, thank you, Kate. From our virtual audience, we have heard some excitement for the use of the surveys that are being proposed for psychedelics and would like to see this for additional drug use. So the question is, what are some of the challenges with funding for basic ethnographic data collection, like what the panel has already discussed?
Oh, I have very strong opinions on this. I'm an epidemiologist, I'm going to speak from that lens, but I think descriptive data is wildly undervalued when it comes to research, and I think this is the perfect example of where descriptive data will actually be so valuable on the front end to inform decision making and things of that nature, but I think that is something that is chronically underfunded. And I think it should be spread out across other drugs as well. So it's the cannabis dedicated survey. It is the kratom dedicated survey. Pick a drug, and we could do much more in-depth work on describing the different use patterns and stuff to inform hypotheses to then do detailed research on. And this is my personal plug that I just think descriptive epidemiology needs to be expanded and funded. I think it's also, speaking of funding, it's hard to find a home for. It's hard to find somebody to fund describing. But that is one place where I would love to see change.
Sounds like a job for philanthropy too.
It could be. Philanthropy, I think, is also a unique element of the psychedelic space. You do see a lot of that occurring.
Well, and I'll just underline that as well. Essentially, especially early on, as we're learning more and more, you need to have that open-ended ethnographic approach to these topics. And, Dr. Jewell, who's not here today, is back in Denver. And the reason why she's back there is because she's writing up all the qualitative data that came from the focus groups that advised Dr. Rockhill's, survey, the Insight survey. The Oregon group has done incredible work on their qualitative tools here of all the clinics that are moving forward in the facilitation that's happening in Oregon. And so, really that work has got to continue, and it will change because use patterns change. So you can't just fund it early on. You have to fund it and then actually make a check back in on the new topics that arise. I'm always amazed by the quotes that come out, and I think that we learn quite a bit more from the quotes, and then we're able to ask smarter questions for the population level work that we do.
Any other questions? Looks like we have a couple.
Thank you all again so much. A.D. Ray, Legacy Research Institute. Something Dr. Dart said earlier about, sort of bifurcating people based on their reasons and motivations for use, reminded me of a lot of what we saw in cannabis, which was that, my predecessors spent a lot of time in drug development trying to find opioids that were analgesic but not rewarding. And that ended up being a dead end because it turns out that you have to feel good to feel better. And that was kind of why, cannabis has been somewhat successful in that it, kind of does tick both of those boxes. And so what that has led me to sort of think about is from the top down, from our healthcare providers, from our department chairs, from the, chairs of committees and all the people who are running federal agencies is, in that spirit of meeting people where we are and following the neurobiology, which tells us there is no difference in the brain between pleasure and pain relief. Following that, kind of thinking about how do we go about from the top down, reimagining the somewhat puritanical idea that it's not okay to feel good and that fun isn't a valid reason for or a valid motivation for use. So I'm curious what you think about that philosophy, or if I'm totally out on a limb here.
Well, that would certainly be novel for medications, therapeutic interventions. We've seen it with other things. Alcohol advertising certainly indicates that it's okay to have fun. I think that also with tobacco we saw that as well. I think it's probably today a bit further for psychedelics, just given the stigma that's attached to psychedelic use and the historical context of also cultural and spiritual uses. I think getting them potentially, those communities on board with that messaging is part of it. But we've seen it with other substances. What we haven't seen it with is medications. And I'm trying to make the analogy with, let's say, SSRIs. But that's treating someone who potentially has depressive symptoms. So the idea that someone should take something for euphoria when they're already not depressed, I think is right now probably a bigger lift. I think when you think about this, the best pathway is potentially defined as the FDA colleague that we had, Marta had mentioned, was find a clinical indication, get approval for that, and move forward from there. Then comes all of the other potential indications that others can use it off-label for. I don't think the medical community yet is ready for prescribing medications to have people feel better than what they normally feel in terms of euphoria. I don't think we're ready to prescribe euphoria. There's too much negative connotations and stigma attached to loss of control, which I think is part of this discussion. Individuals who are intoxicated are not seen to be in control. And that's a messaging issue. I'm not saying I agree or disagree with that, but there's a big messaging problem with regard to that.
It's a really interesting question around like personal philosophy and spirituality and like what the human experience is. And my philosophy is like we are embodied in these flesh suits that our consciousness is in for such a blip of time on this planet. To stop us from feeling the full range of human emotion, including euphoria, is like doing a disservice to the divine. We are supposed to have these experiences. We are also, very much Alan Watts' quote, which is, once you've gotten the message, like hang up the phone. You're not supposed to stay in these states. You're not supposed to feast every day. And there's so much kind of spiritual rhetoric around this, including in Buddhism, which is, what did the Buddha do before enlightenment? Chop wood, carry water. What did the Buddha do after enlightenment? Chop wood, carry water. You're supposed to come back into your home communities and continue the work on repairing the world and raising your families and connecting with your communities. And what we know from addiction research around Rat Park is if we are in a healthy society, like we don't crave the euphoria every day. We crave presence. And so I think the amount of substance use and craving of ecstatic, out of control states is a reflection of how sick our society is. And our desire to dissociate and not want to be here. And so what we can do is if psychedelics do what they're supposed to do and create these ecstatic experiences for us, we're supposed to learn those lessons and then come back here into our bodies, into presence, into sober space, and be able to influence and pass the message on and show up for our friends and family and communities that are still suffering. And so the more we can shift into that, I think the better off the whole industry will be.
Excellent, thank you. We have a large volume of questions, so we're just going to make a little bit more time for a few. So there's been a lot of talk about expanding surveillance to the benefits of psychedelic treatment. What institutions, state agencies, academic organizations are best suited to monitor these in a systematic way?
I won't give the self-serving answer of Rocky Mountain, but but actually, just really what I think about are the attributes of organizations that are best suited to do this, right? And the attributes of places that are open-minded and are independent and actually take a perspective of the entire ecosystem, right? Because I think that if you don't keep those broad views and you're not independent to the findings, essentially regardless of what they show, then you're harmed by not sharing those results with the public, right? And so I guess that's what I would say to start with.
I think one thing I'm going to walk away with today is a newfound drive for more collaboration across the people who are already doing this work. And I think that working in silos, this is the kind of space where that's going to do a huge disservice to the industry at large and could be the downfall of it. So I think, while I think there's a lot of people who could do this work, I also would plug Rocky Mountain, obviously. I do think that we can never do it alone and that we need partners in the tribal communities. We need partners in actual practitioners, and we need to really be looking across disciplines and work together to share information and share learnings. But I do think as I said earlier, I think we need to vet each other's work in this space.
I don't work for Rocky Mountain, so I will say Rocky Mountain.
Thanks, Erica.
I don't think that right now there is the perfect agency or facility. No offense to Rocky Mountain, but the great work that they're doing has come in partnership, and I think that's the key message here is that we're going to have to work together to get a clearer picture so that we will be able to make the right decisions, and that will involve federal partners, tribal partners, and our state and local jurisdictions, as well as those with lived experience. I think we still don't have a clear picture, but there are ways to access insights from each of those stakeholders.
Lisa, did you have a question?
Hi, everyone. Lisa Gora. I'm a health law attorney in New Jersey. And one thing that I want to do is just kind of plant a seed in everyone's mind as it relates to what I've heard and learned today, which I didn't really know was as prevalent as it is, with regards to the misconduct of facilitators. And so because I have the health law background, all of my clients are licensed practitioners. So if an MD or any licensed practitioner does something that is misconduct, they're then subject to their board, their sanctions, their license is reprimanded, limited, rescinded. And so it's, to me, I would think that the simple answer for these facilitators is that they too be held accountable for their actions. And I think because of maybe the way the states are rolling out some of their programs is that facilitators don't have anyone holding them accountable. They don't have board regulations that they're subject to. They don't have a license that can be taken away. So I think that as we consider crafting state models moving forward, I think that anyone that's in the position to be able to craft something where when you're putting together a state model, that maybe the facilitators, anyone that's involved in these programs, be held accountable by some type of licensing board, accreditation board. Because I'll tell you that there's if there is an MD that I'm representing and they engage in some action that is looked at as detrimental to the patient's health, they can be reported to the NPDB. I'm sure the clinicians in this room know about that. If you're working for a licensed facility or hospital, your name gets put on a national list that then will, in some physicians' minds, looks as the death nail to their career, right? So I just think that it's important that we create something to just hold those individuals accountable, and not to obviously scare them. We still want them to be involved in this program, but there has to be something that will deter them from taking those types of actions. And I think that if there is something at the end of the day that someone can come to them and submit a complaint, and then we'll stop them from getting another job somewhere else or them losing their license, I think it may then deter them from taking these actions. So I just kind of plant the seed to say I would think that that's an answer. It may be difficult to create, I suppose, but I think it's something that it's worthwhile considering.
As I've been doing this work and looking at, regulation and board certification on the federal level or the national level and on the state level, and it's very challenging to convince somebody who's been working in the underground for 25, 30 years ethically to buy into a program like that. And right now, there is this, especially with natural medicines, especially with indigenous practice, is the people that get licenses and licensing board, it's very expensive. There's lots of barriers to entry. And what's going to stop somebody in Colorado who's growing their own mushrooms, who doesn't have the economic opportunities or privilege to be able to get licensed and go through all of the education, and so it becomes so incredibly prohibitive to people who are already in practice because they don't have the academic training. And so what we're finding is we're going to create a system, but it's only going to be for people who are people in the super duper medical model. And then 90% of facilitators and people who are doing the work don't qualify for it. And so it turns into you're kind of eating your own tail as you're trying to create the system. And so, yes, it would be great, but it needs to be a low barrier of entry, low cost for facilitators who are lineage and legacy and have been working in this space for a really long time to even want to buy into it. Especially knowing that there's so much institutional harm that has come in against indigenous communities and BIPOC communities. And so it's very complex in that circle of how do we actually regulate this. And Leah and I have been working on this for a while. And so